Good morning, good afternoon, good evening, everyone. I want to welcome you all to this interesting webinar. I am Sergio Aparicio. I'm the current president of the Latin American chapter of IFSO. And this morning, we're going to uh, have this interesting topic, challenges in the surgical treatment of obesity and kidney disease. We have three brilliant speakers. We are going to begin with Dr. Benjamin Clapp from Texas. I'm going to read some of his resume, please. Um, he has been in solo practice uh, for more than 19 years. He's focused on bariatric surgery and the surgery of foregut. He has trained a lot of residents from two different programs and sometimes medical students from Texas Tech in El Paso, Texas. He is now associate clinical professor of surgery for Texas Tech and also work with William Beaumont Army Medical Center in Texas. Um, he has a lot of publications, and now he's going to give us his talk. Benjamin, the microphone is yours.
Thank you so much. Let me share my screen and there. Can everyone see that? Okay, buenos días a todos.
Yeah, we can see.
Y gracias por su invitación. I'm going to do this in English, but if you look at the bottom of the screen, you're going to see subtitles. And of course, most of the slides are in English. So hopefully that will help. This is a picture of El Paso, Texas, here at night. And actually, most of that picture is Juarez, Mexico. Everything in the background, which is maybe 2 to 3 times bigger than El Paso. But we're on the border. And right here, in fact, El Paso doesn't even get on the border. They don't get on the map, but Juarez does. So Juarez is most famous, though, most of all, for this guy. So you guys probably know who he is. He was born there and made his home there and traveled all over the world, making people very happy. You guys all know who he is, right? Maybe the younger ones don't know, but I know that the panel does. So today we're going to talk about the impact of obesity on kidney diseases, the impact of metabolic and bariatric surgery on kidney disease, and discuss kidney transplants, and which is the best metabolic and bariatric surgery for people with obesity that have kidney disease. So I think it's always important, and I tell my students and residents that you can't understand pathophysiology and disease unless you understand anatomy. So we're going to go way back into talking about the kidney. First, chronic kidney disease affects about 2% of the population worldwide. We see much worse outcomes in patients with obesity and chronic kidney disease. Obesity by itself is a cofactor or a comorbidity for kidney disease because you see an increased risk of proteinuria. Now, this can progress on to the chronic kidney disease that even requires dialysis or a kidney transplant, and obesity is very highly associated with those two things. The renal injury that we think is caused by obesity involves a hyperfiltration, which leads to obesity-related focal segmental glomerulosclerosis. So if you have an increased body mass index, if you look at the left of the slide, you get chronic kidney disease stage 3 to 4 to 5, which increases your mortality and the rates of progression to end-stage renal disease, which of course means if you don't get dialysis or transplant, you just die from kidney failure. If you have somebody with kidney failure and they're on hemodialysis, they have a decrease in mortality and they have a decreased chance of getting a transplant if they're obese. So it's a paradox. The treatment is to get a kidney transplant, but if they're obese, they don't get on the kidney transplant list. And if you get a kidney transplant and you're obese, you have an increased risk of dying and you have a decreased risk of long-term graft survival. So it piles on itself. It multiplies on itself and makes things worse. Now, obesity is related to chronic kidney disease and it increases annually because of our obesity rates are increasing annually. makes up 1/3 of all renal disease cases in the United States, which is actually quite striking. 1 out of 3 people that have renal disease are obese. And it's characterized by a proteinuric renal illness in patients with obesity that may not have clinical or histological evidence of other renal disorders. For example, like another IgA nephropathy or something like that, or diabetic nephropathy. This is just by itself from obesity. And that is usually, again, translated as microalbuminuria or significant proteinuria or microscopic hematuria or nephrotic syndrome. So here's a picture of what's going on. We have obesity from high-fat foods, extra calories, just disease of obesity. That leads to glomerular hyperfiltration with activation of the renal angiotensin aldosterone system, insulin resistance, lipotoxicity, inflammation, and changes in your intestinal flora. So all of these things act on chronic kidney disease, causing glomerulomegalia, global focal segmental glomerular sclerosis, podocyte injury, tubulointestinal interstitial fibrosis, and tubular atrophy. So either I just put you right back to sleep or I gave you a panic attack from medical school talking about things like podocytes and glomerular sclerosis. Oh my goodness. See, I haven't said the word podocyte probably since I was a second-year medical school student, but don't panic. We're not going to talk about it too much. You just need to kind of remember that so you remember the mechanism of injury. So the pathophysiology of obesity and chronic kidney disease is that you see obesity-associated tubular lesions that thicken the tubular basement membrane, the tubular epithelial cell hypertrophy, apoptosis, tubular interstitial fibrosis, and inflammatory changes. And here you see on the bottom, you can see the normal glomulus, and then you see the obese one, and then here you see the tubules, which are changing with inflammation, proteinuria, lipid basement membrane is thickened. Now, interestingly enough, and you may or may not remember this from your first year of medical school, but you are only born with a certain number of kidney cells. They do not regenerate. So it's almost like a woman is born with a certain amount of oocytes that she's ever going to have. She's born with like maybe 400. That's all she gets in her entire life. They don't regenerate. She doesn't make new ones. Kidney's the same way. You have your kidney, and that's what you get. Versus the liver, which has the ability to sort of repair, regenerate itself. That doesn't happen with the kidney. Now, interestingly, is the other comorbidities that we have with obesity that we're so used to talking about to our patients, hypertension, hyperlipidemia, obstructive sleep apnea, are all independently linked to worsening renal function. And nearly 50% of patients with chronic kidney disease and end-stage renal disease have nocturnal hypoxia. So when you take those factors, like obesity is already bad for you, and then you take these other things and you add them into the mix, you're really looking at quite a damaging effect on the kidney. Adipose tissue, particularly visceral adipose tissue, is a primary source of cytokine release, such as leptin, adiponectin, tumor necrosis factor, monocyte chemoattractant protein 1, transforming growth factor. All those things that you learned to take your board exam or step 1, step 2, and then you forgot. But they're very important because persistent inflammation is an essential feature of chronic kidney disease, and that contributes to the progressive kidney fibrosis, endothelial dysfunction, and activation of glomerular and tubular epithelial cells, which gets in this cycle of inflammatory chemicals, which attract more immune cells, which damages the kidney more. So it's one of the vicious cycles that we see associated with obesity. And I don't think we talk enough about obesity being an inflammatory disease. It really is. It's the same kind of inflammatory or autoimmune disorder almost that we see with rheumatoid arthritis, things like that, because it's just this chronic persistent inflammation. So you see the release of cytokines, adipokines from adipose tissue, releasing all of these cytokines, causing changes in glomerular filtration, sodium tubular reabsorption, activating the RAS system, and causing more and more inflammation. So this alters the renal hemodynamics. The renal angiotensin aldosterone system is altered. And then you have a dysbiosis of gut microbiota, which we're just learning about. And there's almost seems like there's a journal article every week or every month in surgery for obesity-related diseases or obesity surgery talking about how the gut microbiota interacts with obese patients and changes. So what are the effects of bariatric surgery on renal outcomes and how can we change this? This is a meta-analysis. I picked this because it breaks down 49 articles for you. And the results of this show that we have an improvement of renal function after bariatric surgery. Um, what happens is it's most improved 1 year after surgery, and compared to gastric bypass, in here, sleeve patients benefited more from a reduction in serum creatinine. So what we would see is an improvement in renal function obese patients, especially after 1 year. When you look at this, this is this paper distilled into taking all 49 studies and distilling the data. The glomerular filtration rate difference of preoperative and postoperative in the periods. This is the creatinine difference, and you can see it drop. And then this is the adjusted albumin, I'm sorry, the albumin to creatinine ratio over time. So bariatric surgery can improve renal function in obese patients. It reduces the GFR in patients with hyperfiltration and increases GFR in patients with renal insufficiency. So it normalizes patients on either end of that spectrum. And the incidence of albuminuria, microalbuminuria, and the albumin to creatinine ratio, the unadjusted albumin to creatinine ratio decreases after bariatric surgery. Now, what about the relationship of kidney function body mass index before and after bariatric surgery in patients with chronic kidney disease? And this is a paper from 2021. So this is from we don't have anything like a nationalized healthcare system in the US. We have Medicare and Medicaid, but within certain states, we have health systems that can give us a lot of information. For example, the Mayo Clinic, this one is from the Kaiser Permanente in the West Coast, which is essentially California, Seattle, I'm sorry, Washington and Oregon. And so what they did is they looked at patients that got bariatric surgeries from 2007, 2015, no history of previous procedures, and that's 24,000 patients. They looked at patients with chronic kidney disease, which was 1,100, and then they met the final eligibility criteria, and they had patients get a bypass or get a sleeve, and you can see the numbers there. And what they found is on the left, you can see that the Roux-en-Y gastric bypass and the sleeve at the top are showing the BMI changes. So the bypass outperforms the sleeve, which you would expect. But what you can see is that the trajectories from 2 to 3 years after surgery for the GFRs, which is the lower portions of the slides, show that you have a decrease in the GFR here. This line right here, and this is for the sleeve gastrectomy, farther you get out from surgery. So it slows the decline of your glomerular filtration rate up to 3 years after surgery. Now, the interesting thing is this poorly tracks with changes in the body mass index. You would think it would be a dose-dependent response, where if you have more weight loss, that you would have a better change or a greater change in your GFR. In fact, that's not what we found. This study provides evidence that kidney-related benefits and bariatric surgery may be independent of weight loss. Here, you look at improvement in stabilization of chronic kidney disease after bypass. So these are 45 non-kidney transplant patients with renal disease that undergo bypass. 45 patients, 14 subsequently got a kidney transplant, and 31 didn't. So this is people getting bypass before kidney transplant. And what we found here is it's very safe to do this, but the 2 dialysis patients were able to discontinue dialysis after they got a gastric bypass, which is interesting. And the remaining patients had a stable function. So yeah, it's, these are high-risk patients, but it's worth doing these cases. They have a decreased risk in death in patients with chronic kidney disease. So this is adjusting for end-stage renal disease. Bariatric surgery had a 79% lower 5-year risk of death compared to matched controls. Now, Mike Edwards wrote this paper when he was in Temple before he was at the Mayo Clinic in Florida, and he used our MBSA QIP database, so 350,000 patients. He looked at what operation they got, and their study population was 278,000 without renal disease and 2,000 with, patients on dialysis and patients not on dialysis. And he found that you had higher outcomes of mortality, reoperation, readmission, and things like that. Now, remember, the thing about this database is we only look at 30-day outcomes. These are high-risk patients. I mean, your adjusted odds or relative risk of mortality is 6 times greater. That's really not a surprise to anybody. But again, you have to look at the long-term decrease in mortality, and you have to look at the functioning of their kidneys as they get better from the weight loss. So you take a high risk up front, but you have great rewards in the future. So that's what that slide says. So bariatric surgery improves access to renal transplantation, and it's safe in renal failure as well as after transplantation. So this was published in Transplantation Reviews. Bariatric surgery can be used as a bridge to get people to renal transplant, or you can do it afterwards, and you can find that that's a very safe mechanism. And here they looked at inclusion criteria. They looked at 23 different citations, pre-kidney transplant, post activation when they're on the list, and then after activation when they're on the list, meaning that if you're on a list for transplant, you're probably just floating along not too bad. As you get worse, you move up on the list, right? And then you get what's called activated, meaning you're next up. When somebody dies, you get the kidney. So that's what that. So those are two different groups, and then you have simultaneous bariatric surgery and kidney transplant, and then you have kidney transplant after surgery. And what we found is that if you look at pre-activation, you have a more overall complication rate of 14. You have a death rate is 8.4 per 7, right? So let's think about this number, 14.5. Same group. This is some of their demographics. And then if you look at their 5-year graft failure, it's 9.5%, which is what we want to see. And then if you look at the group that's post-activation, the sicker group, we see the overcomplication rate was 39% versus the 16%. And the graft failure rate still remained about the same. If you look at it post-kidney transplant, you see overall complication rates lower. It's almost like the pre-activation, and you see the graft failure rate is 4%. So it's a big difference. It goes from 15% to 4%. So you can pick either one. What I generally will use is I generally will use a sleeve gastrectomy in these patients. It's just as efficacious. I'm always a little worried about transplant rejection, and I worry about absorption with the gastric bypass, but there is data to support that you can give immunosuppressants after a gastric bypass, and the patient will do fine with graft survival. But I generally will do a sleeve. So our conclusions is obesity is related to chronic kidney disease. Metabolic and bariatric surgery will improve chronic kidney disease, and metabolic and bariatric surgery can be used as a bridge to transplant, or you can do it after transplant. So hopefully I'll see everybody in Tijuana next month at the Congreso Nacional de Cirugía. It's going to be a great conference. There's amazing speakers there, good topics, and I would like to answer any questions if you have any. And hopefully my subtitle thing worked, because that was the first time using it.
Thank you very much, Benjamin. We know that you have to go to the operating theater. Then the panelists can make some questions if you want.
Yeah, if you want to make some questions, that would be perfect. I've got about 15, 20 minutes. Sorry about that, but yeah.
Okay, Otto, you have some comment?
Well, I really wanted to comment that as Benjamin said, sleeve gastrectomy is preferred as a bridge procedure before a kidney transplant. Have you thought, Benjamin, of the difficulties and in the supplementation with the Roux-en-Y bypass?
Yeah, that's a great question. So the thing is one of the things you have to worry about with the bypass is it's a more malabsorptive procedure, not only for vitamins, but also for that's interesting. I'm sorry, I just noticed that my subtitles are still going, so I will make my screen smaller, and then maybe people can follow along a little easier. But yeah, I worry about the rejection of the kidney. And, if you have a graft survival rate of 4%, that's about as good as you're going to get. But when you see graft survivals of 16%, graft failure 16%, that's a big deal. I mean, this person waits for years on the list. If it's a live kidney donor and then we have the kidney, not get rejected because of immunosuppression, that's a really big deal. So what we have to think about, I think, is the best one that's going to give the patient the most chance of long-term graft survival. And I think that's the sleeve gastrectomy. The bypass, I've done it and patients have done well, but I always worry a little bit about the immunosuppression.
Okay, thank you. Mauricio, do you have any comment or questions?
I just want to thank you for the evidence that you presented, and I think the bridge between what we used to do only for weight loss has now come through and in so many other things, and right now in renal disease is very important, and collaboration has just opened up and research has opened up, and we know we can now, using surgery, either improve patients' lives or improve results in transplantation. I think we've come a long way, and you've shown that remarkably, that we can now collaborate and talk and maybe think about surgery not as a terminal or last resort, but use surgery to help patients in this journey, in this case, renal disease that is very, very complicated as it is obesity, and help them improve results with our colleagues, such as Aldo, who's talking next. So I think it was brilliantly presented, and the evidence is great. Looking forward.
Thank you so much. I mean, if you're going to consider doing these, though, you need to have, like you said, it needs to be a multidisciplinary team. The nephrologist has to be on that team, and you have to talk to the patient very clearly about the risk. And they have to be there in the hospital. And it's not going to be the one-day stay, the outpatient. They're going to be there for a little while. One of the saddest cases I had, though, is I did a gastric bypass on a patient. He was a policeman who was developing renal failure from his diabetes, and he had great weight loss, doing well, but 2 years later he developed an oxalate uropathy. So he was forming too much oxalate stones and too much oxalate, and so I had to actually reverse his gastric bypass. And that poor guy was so sad to see his bypass go. But the kidney is an interesting thing, and you have to use your colleagues. They're experts in this, and put yourselves together and help the patient.
There is an excellent question in the question and answers. Right in the bottom. What about using GLP new medications as a bridge before transplant? Says Mohammed.
Is that a surgeon?
We will ask him this.
Yeah, maybe that guy's not a surgeon. No, so that's a gregreat question about the GLP-1. Yeah, so the GLP-1s work very well. They're great. But the problem is they have limitations. So if you have somebody, if 50% of the population loses 10% of their total body weight, for a lot of people, that's not enough. If you're 150 kilograms and you lose, 10%, 15 kilograms, that's still not enough, right? So yes, we can use it as a bridge. Yes, I'm using it as a bridge for surgery. I'm using it after surgery, but it's going to have limitations right, now. Maybe in the future it gets better, but.
Okay. Thank you very much, Benjamin. We are going to move on.
Thank you so much.
Thank you.
I'll stick around for a little bit, but I got to get ready.
Okay. The next speaker is Dr. Aldo Jimenez from Mexico. He's going to talk about the benefits and results of metabolic and bariatric surgery and kidney disease in the short, medium, and long term. I'm going to tell you something about Dr. Aldo. Let me check. He's attending in internal medicine and nephrology at the Instituto de Seguridad y Servicios Sociales de los Trabajadores del Estado. He's now in Los Mochis, Sinaloa. He has a lot of publications, book chapters, and now the microphone is yours, Aldo.
Hello, everyone. Thanks for having me. And I just saw a surgeon talking about podocytes. Now you are looking on a nephrologist talking about Roux-en-Y gastric bypass. And I'm comfortable talking about podocytes, but I'm gonna try to talk about the perspective of the nephrologist on this metabolic surgery. So I hope you enjoy it. So obesity is a well-described risk factor for diabetes, hypertension, and cardiovascular disease in the general population, all of which in turn increase the risk of CKD. On the other hand, obesity is associated with a higher risk of CKD incidence and progression, higher risk of albuminuria, more rapid kidney loss, and a higher risk of end-stage renal disease. In observational studies, if we adjust for the presence of comorbid conditions, the obesity association with worse kidney outcome is independent of diabetes or high blood pressure, suggesting that there is a direct effect of adiposity on the kidneys. This is a complex one with humoral changes like insulin resistance, hyperinsulinemia, RAS activation, with metabolic changes like inflammation, oxidative stress, and abnormal lipid metabolism, and for most hemodynamic changes like glomerular hyperfiltration, tubuloglomerular feedback abnormalities. So this is what happens when the excess of adiposity works in the kidney, and there is a clinical pathologic entity called obesity-induced kidney damage or glomerulopathy, where our colleague just talked about the glomerulomegaly, the abnormal deposits of some stuff on the nephron, but let's not forget that this excess of work that kidney has to make makes damage on the final terms with glomerular sclerosis and kidney failure at last. Or really, the really entity that is for me the most common and is obesity related to is DKD or diabetes kidney disease. And we'd like to talk about the rare stuff, but the DKD, I think, is your everyday problem you solve on your operating room. So, given obesity compelling effects on kidney function and structure, weight loss interventions can be reasonably expected to positively affect the development and progression of CKD. Metabolic bariatric surgery represents the most effective intervention for weight loss, which is increasingly applied in patients with advanced CKD. So I'm gonna talk about some articles that I found most interesting, and this is one of them. This is a systematic review of interventions of weight loss on patients in CKD. It takes CKD stages 1 to 4, around 1,000 patients. And the surgical intervention in these patients compared with non-surgical at 12 months showed average body weight loss of around 30 kilograms, a BMI reduction around 10, and a waist circumference reduction about 30. So this is when someone told me I'm gonna make this presentation, the first that comes to mind is this is what the surgeon must see when they got with this kind of patients. So it's like when you have a game, you have to choose select the difficulty, easy, normal, or hard. So not all CKD stages are created equal. You can have a patient with CKD stage 1 or 2, and that's the most healthy patient, or you can have a patient with eGFR less than 30 or 15, and there is gonna have difficulties with the outcomes and with the complications that we're gonna just talk about in a few minutes. So to put in perspective and manage expectations, I would like to explain something first. So this is the 5 stages of CKD. Stage 1 is a GFR of more than 90, and stage 5 less than 15. And you have a patient of 40 years, the average expectation years of life, if you have stage 2 is 30 years, but if you are in stage 4 or 5 is 10 years of life expectancy. So advanced CKD is on the hard level of your game difficulty giving surgery to these patients. So this is one of the few randomized controlled trials that examples your ordinary patient with easy normal difficulty. This is a single center randomized controlled trial with 100 patients with type 2 diabetes and obesity and early CKD, stage 1 to 3, and albuminuria more than 30 milliliters per minute. And they were randomized to the best medical treatment or Roux-en-Y gastric bypass and follow up for 24 months. And what they found was that in the primary objective was primary outcome, the albuminuria effect of surgery versus best medical treatment. And you got a remission rate of albuminuria of 80% compared with 55, and this was statistically significant. On the secondary outcomes of BMI, A1C, the surgical treatment also was better than the medical treatment. So what is the patient on heart mode? And this is from the nephrologist literature, and we can see that in this retrospective cohort of Medicare with more than 2,000 patients on the years of 26 and 2016, there was a trend of 9 times of bariatric surgery on end-stage renal disease patients, and the procedure of choice was sleep gastrectomy. Complications were similar between patients with and without end-stage kidney disease. However, patients with end-stage kidney disease had more readmissions and slightly longer hospital stays. So the conclusion of the study was that laparoscopic sleep gastrectomy is the most common bariatric surgical procedure in this population, and there is a favorable complication profile. On the other hand, this is another study on these heart mode patients. This is a retrospective database of around 1,000 patients with obese and end-stage renal disease, and the interventions were compared with those with normal kidney function, and the primary outcome was at 30 days. As you see on the right, there were more surgical complications like unplanned reoperation, transfusion, and endoscopic intervention, and more medical complications like unplanned ICU stay or pneumonia. Sorry. So the conclusion of the study was that ESRD was associated with a higher risk of surgical and medical complications compared with normal kidney function. However, the actual difference in outcomes rates was relatively small, with each being 4% or less. So we're dealing with sicker population, not a surprise. So, patients with CKD and ESRD experience high risk of complications compared to those without the disease, although the absolute complications were low. So CKD and ESRD should not be perceived as a contraindication to bariatric surgery. On the second part of this talk, I'm gonna give you the real deal about the patients I see on dialysis rooms. And unfortunately, the survival of this patient is less than many types of cancers. As you can see, the patient on long-term dialysis, the 5-year survival is less than a patient with leukemia or colorectal cancer or kidney cancer or lymphoma. So that is a very striking and eye-opening figure that I found out when I was on my training years. But there is a glimmer of hope or a light at the end of the tunnel, that when you get kidney transplantation, these numbers can change. No, this deceased donor, the kidney can last around 10 years and the living kidney donor around 15 years. So I found this pretty interesting question. And can the long-term health benefits of bariatric surgery can be seen on patients with end-stage renal disease? And this was answered in this retrospective cohort of the USRDS with 1,500 patients versus a matched non-surgical cohort. And the primary outcome was 5-year mortality. And what they found is that bariatric surgery increased survival and increased the incidence of kidney transplant on this population. So yes, there was a benefit on survival that we just saw that these patients have a very bad prognosis. And some series of the Mayo Clinic talking about metabolic surgery as a bridge to transplant. This was a small study with 100 patients, 54 of them with advanced CKD, 60% were on dialysis, and the procedure of choice was sleep gastrectomy, and they were compared to 50 patients who declined surgery. They were candidates, but declined surgery. And of these 54 patients, 20 of them, after surgery, received a transplant during a follow-up of up to 20 months. They lose weight more, they were faster time to transplant waiting list, or 3 more times likely to receive a kidney. So this is a pretty interesting observation of this cohort on patients of the Mayo Clinic. So at the end of the road, when the kidneys stop working and you can't live anymore, the renal replacement therapy, the procedure of choice is a kidney transplant, but the reality is there isn't kidneys for everyone. There is a shortage, a limit of kidney transplants. So unfortunately, the dialysis prevents for most. So what we're trying to do as nephrologists is to preserve kidney function at any cost with an incremental new therapies that we have gotten. And this can slow CKD progression, avoid dialysis, giving better survival and quality of life for our patients. And this is what we do. And the average patient with age-associated decline, as you see on the gray line, is a loss around 1 milliliter per minute per year. But when you got DKD, you can lose an average of GFR of 6 milliliters per minute per year. But when you give these drugs to the patients like RAS inhibition, SGLT2 inhibition, GLP-1, MRIs, you can slow down the progression of CKD on our patients. So what is the role of surgery on these patients? This is a perfect example. We talk about milliliters per year, but if you see on the big picture, if you have a patient with 60 years old and a eGFR average of 56, and the patient lost around 4.6 milliliters per year, but when you give these interventions with drugs and this slope changes to 1.8, you give this patient 15 years of freedom of dialysis. So you see small changes and 1 milliliter, but this 1 milliliter give us a lot of hope and quality of life and survival for our patients. So the role of bariatric surgery, this was a cohort where they look about the eGFR with creatinine and cystatin C, and metabolic surgery was associated with 1 milliliter per year slower decline on patients with CKD, and this great effect was better in those with lower baseline eGFR. So this is another option we got as nephrologists to our patients. And someone asked about the GLP-1, no? So I found this interesting study. This was 400 patients obese with type 2 diabetes and CKD stage 3 and 4, and they compared surgical versus GLP-1 with the primary outcome of CKD progression, and that was eGFR loss of 50% or eGFR less than 15 milliliters per minute or dialysis or transplant. And surprisingly, the patient on the surgery group with a follow-up up to 10 years that was presented in a poster on one of the Congress, there was a slight, a better resolution or less progression with the surgical group versus the GLP-1. So yeah, surgery has a big impact on CKD progression. So to conclude, the short outcomes less than 12 months post-op, we saw renal function improvements, very glycemic optimization, and blood pressure reduction. The intermediate outcomes of 1 to 5 years, we saw a stabilization or slower CKD progression, reduced pharmacological burden, and enhanced functional and quality of life metrics. And on the long term, a lower risk of end-stage renal disease, a survival benefit, and durable metabolic benefits. The take-home points is treatment, the surgical treatment of obesity and its metabolic sequela has the potential to improve management of diabetic and non-diabetic chronic kidney disease and aid in slowing of renal decline toward ESRD. Although complications of metabolic surgery are higher in this population, the absolute numbers are low and it remains a safe intervention in this population. Pre-transplant metabolic surgery increases access to kidney transplantation in patients with obesity and end-stage renal disease. Thank you.
Thank you very much, Aldo.
Understand me well.
Talk. You can stop sharing your screen, please.
You have any questions?
We are missing the nutritionist, Elizabeth. We talked to her last night and there was no problem, but for the time being, he's not online right now. Then we're going to move to some comments. Mauricio, do you have any comment? First of all, I want to present Mauricio. Dr. Mauricio Sierra is a fellow of the American College of Surgeons, is a titular professor and coordinator of the Service of Bariatric and Metabolic Surgery and Laparoscopic Surgery in Instituto Nacional de Nutrición Salvador Subirán in Mexico City. Mauricio, do you have any comment?
Thank you. And again, good morning to everyone, and thank you for the privilege of being with you today. I think both of our speakers have demonstrated how we as surgeons, and Aldo made a very nice comment how he was talking about surgery. And I think we have found, especially in metabolic and bariatric surgery, common ground. And so we can discuss with our colleagues, clinical colleagues, the benefits of their interventions in our patients and our interventions in their patients. And this trying to improve results during disease or before or after, in this case, transplant surgery, for example. So I think both presentations have been exceptional in the sense that there is like this niche of opportunities of conversations between clinicians and surgeons, and especially looking forward to benefit patients. So I am very happy that we have these common talks and spaces to talk about that. And I wanted to ask Aldo, how is your chain of consult when having a patient referred for surgery? How do you do that, especially in a challenging space that is sometimes developing countries, and that we know that transplant surgery is not going to be around the corner? How do you talk, and how would you recommend other nephrologists or surgeons to approach these?
Yeah, that is a good question. So the patient comes to me and they care about the procedure, and everyone talks about the higher risk on this patient in particular. And what I say is, do you prefer to be on dialysis if we still make the same things that we do in 1 or 2 years, or we can take the risk that is not a striking risk and retard or slow down, and you can have 5-10 years without dialysis. So the patients gets it, and we talk the surgeon and about also the benefits, and yeah, we encourage patients to do these things, and like all you have spoken about the multidisciplinary team that is necessary to have good outcomes.
I want to ask you something, Dr. Jimenez. Can you say a word about the nutritional management, special features and challenges in the patient with kidney disease and metabolic and bariatric surgery? And if the panelist can say something about it as well.
Yeah, as nephrologists, the support we get with the nutritionist, and what we know about it is the diet is different when you are on early CKD stages. The diet changes when you are pre-dialysis. The diet changes when you are on dialysis, and the diet changes when you are after dialysis or the transplant. So yeah, it's not the same nutrition for everyone, and the diet changes when you got surgery. So yeah, I think that is the most important point.
Mauricio and Otto, do you have anything to comment about these nutritional special features in kidney disease and metabolic and bariatric surgery?
Actually, yeah, I want to underline something, especially. But before I speak about that, I want to thank you, Sergio, and IFSO and IFSOLAC for the invitation. It's great for us to have the opportunity to share with these great surgeons, these great people in the bariatric world. And it has been remarkable talks that we have heard today. And talking about the nutrition things, we have to take in account the risks with the patient with chronic disease, with chronic kidney disease. We are in front of people that can be dehydrated very soon due to oral intolerance or malabsorption. So the oral intake of enough liquids should be enhanced in the bariatric patient and chronic kidney disease. So we have to be very careful with the electrolyte imbalances, because this patient should be in greater risk of hypokalemia and hypomagnesemia, and we have great difficult adjusting nephrotoxic drugs and their dosage. So the adjustment in the protein intake must be taken very carefully. And as I don't remember if it was Benjamin or Aldo who said that this must be a multidisciplinary job to try to make in good balance this patient. It is really important, not only for the chronic kidney disease patient, but for the ordinary patient, that the multidisciplinary group is in charge of this. And nutritionists, nutriologists, and nephrologists must always be in charge of the follow-up of our bariatric and chronic kidney disease patient.
Mauricio?
I think also as stated, nutrition plays a huge part of patients in treatment and in preparation of procedures. So what I would advise that has been working very well with our team is that, for example, if we have patients with kidney disease, they themselves, as we have done in bariatric surgery and metabolic surgery, have assembled a multidisciplinary team to evaluate and treat these patients. So you have a nutritionist specialized in kidney disease. And that, I think, opens up, again, huge opportunities to improve management of these patients during their ailments, during their disease, or preparing them for surgery. So what I would recommend, and has worked in renal disease, in liver disease, that people form these multidisciplinary teams to improve results. Every patient, independent of their organ problem, needs different things. And again, when we do this focused approach, patients are going to be better during or before during surgery and after surgery, or in preparation for surgery. So I think it's very important that we keep talking about this in forums, surgical and clinical forums. I'm going to Mazatlan this week to talk to an internal medicine group. We need to establish these relationships and to open up opportunities of collaboration with all the multidisciplinary people that are involved in patients with this disease. So I think, and what I would recommend and has improved our results and getting patients to surgery sometimes earlier is these collaborations. We've understood now that it's better to operate early, and people like Aldo, like many other colleagues, have opened up to that and have allowed us to improve patients' lives in preparation to things like transplant surgery that can bring a new life to any patient, no? And that includes patients with liver disease inclusively. So I think it's very important that you surround yourselves with experts and people that are dedicated to patients, specifically with a disease that's going to improve your results.
Okay, we have a question here. We have a question here from Jose Ernesto Escobar. I think it's a fellow surgeon from El Salvador. I'm not sure, but he's asking, are these patients required to have more dialysis? What about the protein supplementation? Aldo, can you talk us about that? You are mute, Aldo.
Yeah, the question was about requiring more dialysis and protein supplementation.
First of all, he's asking if these patients in chronic kidney disease after the bariatric surgery should have more dialysis. And the other part of the question is, what about the protein supplementation? If it's going to be, the protein supplementation should be changed, diminished or something.
Yeah, about the more dialysis, it is a no. The dialysis schedule doesn't change. There is some series of patients who had peritoneal dialysis, and they got bariatric surgery, and they can resume the dialysis in a few weeks after. And about the hemodialysis patients, there isn't a change. It's like if the patients have a residual kidney disease, and they can have twice weekly, but the average patient needs 3 times a week for hemodialysis. And about the protein supplementation, in the actual recommendations of KDIGO, who is the guidelines of or CKD patients, is that the patient does with early CKD doesn't benefit from a low protein diet, and the patient with advanced CKD or pre-dialysis, yes, they benefit from a low protein diet. On the patient with bariatric surgery with malabsorption, etc., yeah, we can give supplements to them.
Okay, and talking about sorry, Sergio. Talking about the need for dialysis, it will only change if the patient goes to kidney transplantation. If the patient doesn't undergo kidney transplantation, the need for dialysis will be the same with or without the bariatric surgery.
Yeah, it was an interesting study from the Mayo Clinic where they in a small population there was a preemptive kidney transplant with bariatric surgery. So these patients were on pre-dialysis, and if things go the way they should, they will never get a kidney. So for the restrictions of the BMI on being on the kidney transplant. So on these patients on pre-dialysis, if you have a bariatric surgery, you can get them a preemptive kidney transplant without passing for dialysis. So I think that is the exact timing for surgery.
I see that we have a nutritionist, Elizabeth Tavares, online, but we don't have too much time. We have 2 or 3 minutes. Elizabeth, can you give us something, some views about the nutrition of patients with impaired kidney function and metabolic and bariatric surgery in 2 or 3 minutes? Elizabeth, please.
Yes. Well, the management, the nutrition management of population that undergoing to surgery to lose weight, we need to divide it in 3 groups. Persons with conservative treatment that dialysis and kidney transplant. It's important to focus the metabolism of the overweight in this population is different. And we need to take care a lot of prevent risk of malnutrition, sarcopenia, and loose muscle tissue. So we need to adapt the guidelines of nutritionists for kidney disease to the surgery, and a special supplementation for protein, calcium, vitamin D, vitamin B12, and iron as well.
There is one last question, please, from the audience. How concerned should we be about the risk of kidney stones or post-bariatric surgery in this patient cohort? Should we proactive in negating the risk, and does this influence type of surgery selection? Some of the surgeons can answer this question. Maybe Aldo.
I'm going to talk a little bit about this. We will be, especially in the bypass group, we will be clearly taking care of kidney stones. It has been one of the difficulties or one of the undesirable outcomes of the bypass surgery. So we must be taking care of this, being able to, as we talked before, we have to give enough liquids to these patients to avoid dehydration, because this will enhance or this will make easier to the patient to have kidney stones. So we have to be careful about this.
Thank you. And some changes in the supplementation as well.
Yeah.
I want to close this webinar. We are just about to finish. I think that we have to state that bariatric and metabolic surgery, first of all, improves kidney function and avoids the progression of this disease. And bariatric and metabolic surgery serves as well as a bridge to kidney transplantation in some cases. We have to work with the multidisciplinary team. It's important to have a nephrologist in this team, and the special features in nutrition, supplementation in these patients is important as well. I want to thank all the speakers and the panelists, and to the audience, thank you for attending this interesting webinar, and see you next time. Bye-bye, everyone.
Thank you. Thank you all.
Thank you all. Have a good day.